Good morning, good afternoon, everyone. I think we're going to go ahead and get started today, just so we can kind of move through a really robust agenda we have. But my name is Sarah Hamilton. I use she, her pronouns, and I'm the Director of Operations at Funders Concerned About AIDS. For those of you who are new to FCA, we're a philanthropy-serving organization dedicated to mobilizing resources to end the global HIV pandemic and building the social, political, and economic commitments necessary to attain health and human rights for all. On behalf of our partners, amfAR and Funders for Reproductive Equity, I'm delighted to welcome you today to this webinar, Advancing Global Health Equity, Investing in Integrated HIV, HPV, and Cervical Cancer Initiatives. Before we get started, I want to go over a few logistics. Kat, if you can advance the slide. We encourage you to, today will be a webinar format, which means you won't be on screen, but you'll have access to the chat and Q&A functions. So we really encourage you to consider introducing yourself in the chat with your name, pronouns, and where you're joining from today. We'll also be recording this conversation and we'll be sharing that after the call, and captions will be enabled at the bottom of the screen. Today we'll be monitoring activity in the Q&A, and we will be taking questions from you in that method at the moderated conversation portion, but we just ask attendees prioritize rights-based and inclusive language in your interactions. This is a non-solicitation space and is a dialogue intended foremost for donor institutions. If you wear multiple hats at your organizations, we really ask you to consider your role as a funder in your questions today. So let's get started, shall we? Just to tell you a little bit about what we want to do today, at FCA, it's part of our mission to make clear that the people and places most impacted by HIV are often the same that are shared by broader philanthropy and across geographies and funding portfolios. When amfAR first approached us with this idea for the webinar, we really saw the clear ways in which HIV and cervical cancer intersect. We knew it was a really critical time and opportunity to bring donors together. Even from our own resource tracking data, we know there's an enormous gap in sort of between need and available resources. For example, in 2022, just around 1 million in grants from HIV-related philanthropy included either a reference to or a focus on cervical cancer, or HPV, and HIV. So we know with that number, it's essential to partner and mobilize funding and attention to these issues, not only within HIV philanthropy, but beyond if we really want to address the issues. And to that end, we again are incredibly grateful for Funders for Reproductive Equity for their partnership and for helping us broaden the audience and perspective for this discussion. So for today's agenda, we will work to set the stage and introduce us to research in the field, share perspectives on what the current initiatives look like, and if and how that programming is being integrated on the ground. And then we'll work towards sort of points of advocacy that can inform donors' next steps. Luckily, we will have some really powerful experts with us today. To set the scene, we will first hear an overview of overlapping data between HIV and HPV and trends in the current research. To that end, we couldn't be in better hands today. We're thrilled to have Dr. Carla Chaboisha, Associate Professor in the Division of Global Women's Health at the University of North Carolina at Chapel Hill with us today. The majority of her work is focused on cervical cancer prevention in the Global South with a special interest in the intersection between HPV and HIV. You can find her full and distinguished bio in the chat here in a second. And with that, I'm pleased to introduce Dr. Chaboisha.
Thanks so much for the introduction, Sarah, and for the opportunity to talk about a topic that I have spent my entire career working on. Can you hear me okay before I get started?
Yes, it's great.
Fantastic. As you mentioned, I will be setting the stage and talking at a relatively high level about the overlapping epidemics of HPV and HIV, with particular attention to the Global South. Whoops, I went too many slides too forward. Please, can I ask you to advance slides? I'm not doing it properly. Thank you very much. So before I get into the specifics of cervical cancer, just a little bit of an overview for everyone joining the webinar today. It's well established from a scientific perspective that people living with HIV are at increased risk of certain cancers. In the early years of HIV and AIDS, the so-called AIDS-defining cancers were the most prevalent cancers, and these include non-Hodgkin's lymphoma, Kaposi sarcoma, and of course, cervical cancer. There are also other HPV-related cancers, as you see in blue, like oropharyngeal cancer, vulvar cancer, and penile and anal cancer, which are more prevalent in people living with HIV. And these, together with Hodgkin's lymphoma, lung cancer, and hepatocellular cancer, make up the non-AIDS defining cancers. On the right side of the slide is an image or a graphic that shows trends in cancer among people living with HIV in the US. And you can see that around the time of the introduction of antiretroviral treatment and specifically HAART introduction, rates of AIDS-defining cancers, which are indicated in the mustardish color, started to decrease dramatically. That was driven by decreases in the rates of non-Hodgkin's lymphoma and KS primarily, and to a much lesser degree, decreases in cervical cancer. Over time, you can also see that the share of non-AIDS defining cancers, particularly the HPV-associated non-AIDS defining cancers, has been growing. Obviously, this graphic ends at 2005, but non-AIDS defining cancers, rates of non-AIDS defining cancers certainly continue to grow in the US and globally. Next slide, please. As I'd mentioned, we haven't seen commensurate decreases in cervical cancer since the introduction of ART. And just as an illustration of that, I included a graphic from a publication from South Africa, which reports data on cancer rates in people living with HIV between 2004 and 2014. And you can see in the right-hand side middle panel is cervical cancer. You can see just marked increases over time in rates of cervical cancer, similar to increases in rates of other HPV-associated cancers. Immediately next to cervical cancer is, of course, vulvar cancer and penile cancer, and on the lower portion of the graphic is anal cancer. Next slide, please. And while these increases in cervical cancer in women living with HIV in, for example, South Africa and similar countries are, of course, occurring against a backdrop of rising cervical cancer cases and cervical cancer deaths globally. So each year, nearly 700,000 women are newly diagnosed with cervical cancer. Most of these cases occurring in Africa, Southeast Asia, and Latin America, as indicated in the dark blue in this slide. Geographic variation in the rates of cervical cancer is due to differences in the availability of prevention services, such as vaccination and screening, as well, of course, to differences in prevalence of HPV and HIV. Next slide, please. Here you see geographic variation in cervical cancer deaths, which is due to differential access to surgery and radiation, which are the main treatment modalities for cervical cancer. Next slide, please. So I'd mentioned earlier the contribution of HIV to the difference in cervical cancer rates between the global north and the global south. And of course, I'd like to talk a little bit more about that and the intersecting epidemics. This slide is just here, obviously, as a graphical representation, that the epicenter of the HIV epidemic is in sub-Saharan Africa. Next slide, please. So the prevalence of HPV, which is the necessary cause of virtually all cervical cancers, is extremely high in women living with HIV. In the early years of the epidemic, when ART was less prevalent, we commonly saw HPV rates approaching 90%. More recently, prevalence studies, will typically place HPV infection rates for women living with HIV around 40 to 50%. So still quite high when compared to women without HIV, where rates are typically lower than 20%. Co-infection with multiple different types of HPV is also more common in women living with HIV, and an HPV infection is more likely to persist, and then persistent infection, if unrecognized, can go on to cause pre-invasive and invasive cancer. We have quite a lot of evidence to show that rates of pre-invasive cancer consequent to the high HPV infection rates are 2 to 3 times higher in women with HIV than in women without HIV. And also that rates of invasive cancer are up to 6 times higher than in women without HIV. So that certainly causes an increased burden of disease in areas that are the least well equipped to deal with that increased burden. And then on top of that, both pre-cancer and invasive cancer are harder to treat in women with HIV. I'll touch a little bit on why pre-cancer is harder to treat a little bit later on. The issues with invasive cancer, I'm happy to take questions about later, but I think they're a little bit beyond the scope of this intro. Next slide, please. Thank you. Of course, the situation need not be as dire as it is. We have a very good scientific understanding of cervical cancer and HPV infection and what's needed to prevent it. On the slide here is a graphical representation of the pathogenesis of cervical cancer. On the left-hand side is a representation of normal cervical epithelium, which can then become infected with HPV. If that HPV persists and integrates into human DNA, you can get the development of cervical precancer, which is also known as CIN2 or 3. And if cervical precancer is undetected and untreated, over time that will develop into invasive carcinoma. Cure rates for cervical precancer and cancer in women without HIV, as I mentioned, are extremely high. But even with HIV, we should be able to, with functioning health systems, good referral patterns, good access to care, we should be able to see a picture different from what we're seeing. So moving, sorry, please go back to that same slide. Thank you. Moving again to primary prevention. As I'd mentioned, virtually all cervical cancers are caused by HPV, which is transmitted sexually, of course, and infects cells of the skin, genital area, and throat. HPV 16 and 18 are responsible for about 2/3 of all cervical cancer cases globally, and we have excellent vaccines to protect against HPV 16, 18, and other HPV types. These vaccines are also safe and effective for people living with HIV, and yet only 20% of girls and young women and even fewer boys and young men are vaccinated globally. Next slide, please. Thank you. So on this slide, I've tried to just highlight some of the issues that create the inequities in cancer cases and outcomes that we'd seen on the previous slides. I've just been talking about limited access to vaccination, which of course, is something that we all need to work very hard to address. There's also very limited access to screening for cervical cancer, particularly in the most affected areas in Africa, where it's estimated that only a third of women have undergone screening in their lifetime. Because of the well-defined precancer stages, obviously screening, which was described on the prior slide, obviously screening creates an additional opportunity for prevention. We have relatively good screening tests, but access is very limited to them, and they are also limited by the fact that women typically require multiple screens over the course of their lifetime to fully benefit from the prevention potential of screening. And then, of course, together with screening and in order to actually prevent invasive cancer, we have to be able to detect and treat the precancerous stage. In particularly in Africa, precancer has been extremely difficult to scale because of limited health resources, and some of the technical requirements for excision, which is the more effective of the two approaches for precancer. There are also some particular or special considerations for women living with HIV, which I'll address on a subsequent slide, specific to treatment. Next slide, please. So all that said, there are many innovative screening programs in Africa, Southeast Asia, and Latin America. Obviously, I'm not able to go through specifics of the most innovative ones here, but they all demonstrate that secondary prevention is feasible and cost-effective, particularly in the highest burden areas. Newer demonstration projects have demonstrated that primary HPV screening can be scaled very effectively, especially if it leverages existing cervical screening programs that had either used cytology, which was the first screening method developed, or visual screening, which was a method developed particularly for implementation in low resource settings. And so building on programs that had not achieved the coverage that they ought to have, but had some of the infrastructure. I think primary screening, can be scaled very effectively. Self-testing for HPV is also becoming more common. For example, in the US, within the last couple of weeks, the FDA has just approved self-collection, and there are many demonstration projects across the continent here that show how self-collected testing can be implemented and can be integrated into same-day screen and treat programs. So I think all of that is encouraging, and is kind of a good place to continue building off of. As I'd mentioned, there is the special consideration for women with HIV around treatment. And that's because standard treatment, whether ablative or excisional, ends up not being as effective for these women, and ends up failing within about 2 years for 50 to 30 to 50% of cases, so resulting in a recurrent precancer that needs to be treated again. There are two underlying scientific theories about that. One is that we might not be able to fully treat precancer lesions, leaving behind some in the excision or the ablation. So that's the residual disease theory. And the second theory is that women with HIV become rapidly reinfected with another HPV type, or experience a reactivation of underlying HPV infection at the time of treatment because of immune activation that's going on in the genital tract related to surgical treatment. Next slide, please. There's several groups around the world that are actively investigating new approaches to cervical cancer treatment in pre-cancer treatment in women living with HIV. And I just put on this slide an example of two studies that I'm involved in that address, or that attempt to address, those two hypotheses about what's causing the increased failure rates in women with HIV. I'm happy to speak more about those later if folks have questions. Next slide, please. I'm going to start wrapping up as well. So it's obviously very challenging to cover all of the biological issues and the context-specific factors that contribute to the high rates of cervical cancer in women with HIV in such a short time. But before I move on to my summary slide, I just want to take a few moments to kind of recognize how exciting it is for those of us who work in this field day in and day out to hear about funders like yourselves being interested in this space, and also to see the renewed global interest in cervical cancer prevention, including with HIV funders and non-HIV funders. I think that the global elimination targets that have been set forth by WHO have really, and were made public in about 3 years ago. I think they've really galvanized a lot of attention, interest, and new funders into this space, which again is very exciting for us. Just to highlight the global strategy, the sort of foundation of this global strategy is vaccination, with a global target for 90% of girls and young women to be vaccinated by age 15. Together with vaccination, of course, comes screening, particularly for young women or older women who are not eligible for vaccination. And the global target here is to achieve a screening rate or screening coverage of 70%, linking that to appropriate treatment in virtually all women who need it. We're, of course, a long way off from these targets. As I'd mentioned previously, global vaccine coverage for girls and young women is only about 20%, so a long way to go. And screening coverage in the highest burden areas, only about 30%, also a long way to go. I'll move to my summary slide, please. So the sociodemographic, behavioral, and biological overlap between HIV and HPV results in a high burden of cervical cancer in women with HIV. HPV vaccination is safe, highly effective, and well tolerated in individuals with HIV, and is certainly part of most global recommendations for or policy for HIV treatment and management. HPV screening prevents cervical cancer and is cost effective. And novel programs, including those that use self-testing, I think are the ones to watch. However, additional research is needed to develop more effective pre-cancer treatments for women with HIV. And then, of course, integration of cervical cancer prevention services into HIV care is imperative to expand access. Thanks very much.
Thank you so much for that, both for the work that you
Sarah,
do.
we're taking questions at the end, correct?
Correct, yes, I was going to mention that.
Okay.
I just wanted to thank you again for so clearly setting the scene for the need for this conversation, and of course for the work that you do. So we're so grateful to have you here. And as we just kind of mentioned, if you have any clarifying questions or things that you'd like to ask, feel free to add them to the Q&A or the chat, and then we'll be sure to get to those during the moderated portion of our call today. So I just wanted to mention. So next up, we're going to do a kind of a series of presentations. We're going to really look at sort of programming and policy initiatives that start from the White House down to clinics on the ground. And then after that, we will pause for moderated conversation. But first up, we're going to start with the White House. We are thrilled today to have with us Dr. Catherine Young, who serves at the White House Office of Science and Technology Policy to advance the Cancer Moonshot, the President and First Lady's mission to decrease the number of cancer deaths by 50% over the next 25 years. Besides Catherine's federal government experience, her career has spanned a variety of sectors, including academia, nonprofit, biotech, and foreign government, all with a focus on advancing science. All right, Catherine, the floor is yours.
Thank you so much, Sarah, and good morning to everyone. I'm really honored to be able to share this time with you and provide a few remarks on such an important topic. Just to note, my internet has kicked me out twice since I've logged on, but I am calling also through my phone, so I'm hoping that if my face disappears from you, my voice will continue as well. As mentioned, my name is Catherine Young, and I currently serve as the Assistant Director for the Cancer Moonshot, an initiative that began by then Vice President in 2016 and was reignited by now President Biden and the First Lady about 2 years ago. And for those of you who may not be too familiar with the Cancer Moonshot, it is an initiative that seeks to reduce the cancer death rate in the United States by 50% over the next 25 years. And although I'm speaking as a scientist, and I know there are probably many who are listening virtually who love numbers and stats just as much as I do, the President and First Lady always impress upon us that this goal, and I know I'm preaching to the choir here, is so much more than numbers. These numbers represent real people. They represent our parents, our children, our loved ones, all looking for more time together. And that is why there is a second goal to the Cancer Moonshot, and that is to improve the experience of those living with and surviving cancer. The Cancer Moonshot team, we sit at the White House Office of Science and Technology Policy, and it really is our job to ensure the President's audacious goals are reached. Is it easy? No, but my favorite quote by President Biden is this one: America is the only nation that can be defined by one word: possibilities. And the White House Office of Science and Technology Policy works to bring that idea to life by harnessing the power of science, technology, and innovation to really achieve America's great aspirations. And I'm incredibly grateful that today's convening serves to bring the science, the technology, the innovation, the advocacy, and the policy conversations all to light as it relates to this really incredible opportunity that we have to make a difference in the life of women around the world. And while I currently have the privilege to serve the American people, I was born and raised in South Africa, a country where in some communities, 60% of women have HIV, and where nearly 4,500 South Africans are newly infected every week. a country where 1/3 of those HIV positive are adolescent girls or young women, those who are of reproductive and working age, those that serve as the backbone of the country, the backbone of really every country. And even more critically, as Dr. Chibwesha pointed out so elegantly, those that are HIV positive are 6 times more likely to be diagnosed with cervical cancer. And I sigh very heavily every time I say this, because cervical cancer is not only a treatable disease, but more importantly, entirely preventable if detected early. Yet it remains one of the leading causes of cancer-related deaths among women. So when we talk about gender inequities, this is what we're talking about. The fact that women are still dying today from a completely preventable disease. And the connection between HIV and cervical cancer, as was made so clearly in the presentation before, not only underscores the importance of an integrative healthcare approach to effectively manage and mitigate the impact of both of these diseases, but also presents us with an incredible and powerful opportunity to redefine how our communities can work together to holistically approach women's health, especially in low and middle income countries where disparities and inequalities are only magnified. In a stark illustration of this, over 1/3 of cervical cancer deaths occur globally occur in sub-Saharan Africa, although that region only represents 14% of the world's female population. So my bottom line up front is this: focusing our efforts on both HIV and cervical cancer is not just a medical necessity, it is a moral imperative. By prioritizing these areas together, we can enhance the quality of life for millions of women, reduce mortality rates, promote gender equality in healthcare access, and most importantly, keep families together. A vision that the President and First Lady truly hold close to their hearts. And it is because of this that the Cancer Moonshot, while historically a domestic-focused initiative, has expanded its focus globally over the past year or so, because we believe that everyone around the world deserves the same opportunity to live a long, healthy, and prosperous life. And so I'd like to take just a few moments to share some of the administration's efforts to not only eliminate cervical cancer, but to ensure an integrative and innovative approach. At the forefront of our efforts is the President's Emergency Plan for AIDS Relief, also known as PEPFAR. In 2018, PEPFAR, with the support from our colleagues at USAID, began a concerted effort to invest in cervical cancer screening and treatments for women through the Go Further Partnership, which leverages PEPFAR, UNAIDS, the George W. Bush Institute, Merck, and Roche to provide women living with HIV access to same-day cervical cancer screening and treatment of precancerous lesions in the 12 African countries with the highest HIV prevalence and cervical cancer incidence rates. To date, PEPFAR has invested over $200 million to conduct 7.4 million cervical cancer screenings in over 5.5 million women, and has treated more than 300,000 women for precancerous lesions. Importantly, this year, the Go Further Partnership is enhancing its focus on providing cervical cancer screenings for women living with HIV and scaling up high precision testing, such as HPV testing, through the screen, triage, and treat approach. In addition, last year, PEPFAR announced on the International Day of the Girl that they will support global efforts to increase HPV vaccination among girls. This new initiative has the potential to reach over 1.6 million girls with HPV vaccinations in 15 countries and potentially avert more than 40,000 cervical cancer cases, prevent more than 30,000 cervical cancer deaths, and lead to an estimated 6% reduction in HIV incidence in this group of girls. And while it is absolutely imperative that we maintain a global perspective, I'd like to take just a moment to lift the curtain here in the United States, because according to the American Cancer Society, there will be approximately 13,000 women diagnosed with cervical cancer and over 4,000 cancer deaths this year in the US alone. And more strikingly, Black and Native American women have a 65% increased risk of mortality compared to their white counterparts. So the disparities we see around the globe, we can just turn and find in our own backyard. To end HPV-related cancers like cervical cancers, the Biden Cancer Moonshot is working to do a couple of things. The first is to reduce cervical cancer through increased vaccination to prevent more cancers before they start. To reduce disparities in cervical cancer screening access by bringing screening closer to communities. This includes efforts made possible by a $1 billion commitment from the CDC to provide every state, tribal nation, and territory funding to be able to do so. To support the development of less invasive screening tools and evidence around screening for additional HPV-related cancers through work conducted by the National Cancer Institute, and especially through the NCI Center for Global Health, and to drive innovation to improve patient outcomes. This includes the launch of a new research agency called ARPA-H, whose mission is to fundamentally transform how we prevent, detect, and treat cancer and other diseases and improve health outcomes. And it is based on the model of the Department of Defense agency called DARPA that created technology that has transformed our society, like the internet, GPS, and Siri. And just this February, the First Lady announced that over the next year, ARPA-H will invest over $100 million for the Sprint for Women Health, an initiative that will address critical unmet challenges in women's health and champion transformative innovations to tackle health conditions that are either uniquely or disproportionately affecting women. Together with the newly created White House Initiative on Women's Health, the Biden-Harris administration will work together with all communities to write new stories about women's healthcare, stories where women aren't just an afterthought, but a first thought. This initiative is designed to accelerate your ideas and build a healthcare system that puts women and their lived experiences at its center, which is also a core tenet of the Cancer Moonshot, where women don't just survive with chronic conditions like HIV or cervical cancer, but lead long and healthy lives and live to their fullest potential. And so I want to end here where President Biden usually starts, and that is with hope. And I don't mean to tell this virtual audience that we mean hope in the abstract. We mean hope grounded in science, hope grounded in quality care, hope grounded in keeping families together, hope represented by everyone here today, working towards a day where we can cure HIV and eliminate cervical cancer once and for all. Thank you so much for your time here today. And with that, I will turn it back over to Sarah.
Thank you so much, Catherine. And it's always great to have that message of hope. And we also thank you for bringing in sort of the conversation about equity and disparities as we move forward. And looking forward to in the conversation thinking about ways in which philanthropy can support sort of the Moonshot initiatives as well. Next, we're going to kind of, actually, we're really excited to hear from Smilka Duodasene from Unit Aid, which, as you probably know, is, or some of you may know, is an institution really at the forefront of scaling up initiatives that are focused on this intersection of HIV and cervical cancer. Excuse me, Smilka has worked as, I'm sorry, give me 1 second. Sorry, just having one little bit of a technical issue. All right. At UNAIDS, Smilka oversees the UNAIDS cervical cancer and TB diagnostics investment portfolios. And before joining UNAIDS, she worked as a technical and advocacy officer at the WHO Regional Office for Europe, providing technical guidance on TB and HIV co-infection, as well as HIV prevention in key populations. Prior to that, she was the executive director at the European AIDS Treatment Group. So we're really excited to welcome Smilka to the floor, and I'm going to pass over the mic to you.
Thanks so much, Sarah, and really exciting to be here. Also to come after the two amazing scene-setting presentations and very inspirational messages that have been conveyed. I think as well, UNITAID, as you know, is an organization that is very much focused on understanding where we are with innovation to tackle some of the diseases that have been especially kind of prevalent in low and middle income countries. And in 2018, when Dr. Tedros launched the call for action against cervical cancer, we looked into kind of the palette of different ways of responding to cervical cancer and really focused on what we can do in the secondary prevention, especially given that we, as we heard from the first presentation, there are tools that are high performing, but also can bring us much closer to communities and to women that are in the greatest needs of actually cervical cancer prevention and actually improvement of their cervical health. So if you look into the second slide, next slide, we did in 2018 when we were scoping where we can invest, and we were taking the HIV lens, so the co-infection lens, but then when we started implementing, we actually went much broader than that because we realized that we cannot focus only on co-infection, but that actually there are so many women in need of these services. We focused on laying the groundwork for cervical cancer screening and treatment, and through introduction of new tools and technologies. And this was in partnership with the Clinton Health Access Initiative, Expertise France, and their consortium with JPIGO, UICC, and also we provided support to WHO's program on cervical cancer. And it was a three-pronged approach where we looked at first and foremost introducing HPV tests. As we heard, they are high-performing ways of screening. They are cost-effective and less invasive, especially if you couple them with the self-collection, which really brings that element of greater autonomy. It is more bringing that convenience and acceptability to how the exam is being performed and how the screening actually is being performed. And then on the other hand, we were thinking about at that point, two new products on the market, which were much more easy to use and portable and more affordable. And these were the thermal ablation devices. And to date, we have invested more than 80 million, and we do remain the largest funder of innovative tools across these dimensions to find and treat women with pre-cancer living in low-resource settings. Next slide. And I wanted to focus a little bit on, in this presentation on some of the key highlights and to really draw the kind of connections between some of the elements of the HIV response that we have observed over the last 30 years. And I want to say one of the things that we probably walked into without complete consideration and was one of our biggest learning is that cancer programs across the world are pretty much in their nascence and a lot of expectations around how quickly we can move and how broad we can expand these programs have to be tailored to you know the speed of these programs growing. And sometimes you know we worked a lot and all of us work a lot in HIV programs that exist since 30 plus years, and innovations in the context of HIV programs are much easier to implement because there is an existing ecosystem and the service provision. And pretty much if you click just once, you know, if you see what kind of issues we faced when we started working in 2019, is that across every step of care, we had to address different issues. First and foremost, screening not being offered. So that kind of even just the practice of having the screening sites open and then also reach the women had to be addressed. Then we had where the screening was offered. The test used was the VIA, and you have heard about some of the issues around VIA, especially around its performance. And then when the screening turned to be positive, we needed the women needed to travel long distance to secondary or tertiary hospital for treatment using cryotherapy. And this, if the cryotherapy existed, and if the cryotherapy tool was actually functional. And I have seen many places across the world where actually those balloons of gas were empty and not in use. And then, of course, the suboptimal follow-up care for women who screen positive. And if you click once again, so a lot of the things that we started addressing was really to see how we can first and foremost do this with an integration approach. And this was probably something that was the lowest hanging fruit, especially knowing that we had a lot of investments going on in especially HIV services. So it was easy to build on that. So we were looking at women visiting first and foremost ART clinics and HIV sites, and also those visiting any primary healthcare facilities or family planning and MCH. Then we kind of try to shift into providing screening through HPV testing and where we were available. And then VIA, and we tried also some of the AI-based solutions to improve the accuracy of VIA tests, which we are still working on. And then for those women screening positive, we shifted it into having the lesions treated on the same day at the same facility, which was a very important component of actually succeeding very high rates of treatment due to that kind of shift. Especially having the TA devices on site, but also task shifting to nurses and lower health cadre for some of these practices. And then, of course, client tracking mechanisms to ensure the appropriate follow-up care. And if you click once more, just a little bit of a highlights, I think one of the things is really that kind of huge increase in sites and in capacity of healthcare workers across 14 countries where we worked, as well as the number of women screened, but also quite a large number screened with HPV tests. And then, as you can see, the treatment completion rate was very high and kind of nearing the WHO's target of 90. And we deployed in almost 1/5 of all LMICs, we deployed around 5,700 TA devices. And this number was really about stabilizing the market of TA devices, as well as kind of showcasing and providing that catalytic support to countries to know the tool and to introduce the tool. Next slide. I wanted to probably zoom into HPV testing implementation. And it is, you know, in 2013, when WHO launched the recommendation that HIV treatment should be, the monitoring of the success of HIV treatment should be done with viral load testing. There has been a lot of effort to introduce the molecular testing capacity across countries with the highest burden of HIV. And COVID demonstrated how that could then be used for COVID. And I think one of the core approaches that we used for HPV testing introduction was to take that molecular capacity and expand it to expand its use to HPV testing as well. you can see the cascade, and I'm bringing this study that is actually published, and I wanted to kind of zoom into one component, which I think is one of the biggest issues that we need to think about and resolve, especially given our success in the HIV service provision, which is that we are seeing consistently, even though we are definitely seeing high rates of treatment. The biggest delay and the biggest loss to follow-up happens between the testing and then the results received. And this is something that across different contexts, across different modalities, whether it is on-site or off-site screening and laboratory provision, is something that definitely represents collective task for the future on resolving. And then the second one, I wanted to say that, but that in the context also that the same day test triage and treat was very difficult to achieve due to the HPV testing not being prioritized on point of care devices, especially if you see other tests that the healthcare center had to conduct, such as TB or point of care EID or point of care viral load, were prioritized. So one also major finding and demonstration is that the self-sampling was definitely feasible and acceptable, and that was kind of revolutionary for both women as well as healthcare providers. Next slide. And actually, you can see here that in countries where we offer them, and we offer them in most of the countries where we worked, we have seen very high acceptance of self-collection. It was acceptable, provided greater flexibility, but also task shifting as well, liberated that healthcare worker capacity, and they could actually screen more women versus if they had to do the pelvic exam. And we have renewed our investments to try out the modality of providing self-collection in communities. So through healthcare workers who go, or community health workers who go into the community, deliver different packages of self-care, and we're trying to include actually self-collection there as well. Next slide. I wanted to just also address the thermal ablation device, and today we're talking about a less than $1,000 product that can be procured and used, and it's on the left side of the screen you can see that there is really the ease of use. First and foremost, we're talking about portable, battery operated, easy operation, a type of device that also it's straightforward to the extent that it can really be easy also from the perspective of task shifting. But also it allowed us, I have seen so many different interesting models where, the nurse would pack it in their bag and go into the community and do actually screening and thermal ablation in the communities, in the tents, and that was revolutionary as well from the perspective of reaching more women. Ease of procurement, and I think also interesting what we are seeing on the ground, and when we plug in all the costs that we have been observing, is that in comparison to cryotherapy, there is a very huge cost reduction per woman, and we are talking about 75%. I wanted to probably end there just to see whether there is a next slide. I wanted to also allow enough time for conversation. But just to end that, frankly, most of this success we have seen was based on lessons learned from the HIV response, and a lot of kind of strategies and service delivery models were built off of that. Thank you.
Thank you so much. That was really grateful to have seen some of what UNAID has accomplished, but also like that really fascinating historical perspective on what can be done, regardless of resources and things. So we really thank you for that. And I think it's a very important grounding And I think it will partner very well with our next speaker. We're excited to welcome Dr. Akintadi, the Director for Sexual and Reproductive Health at the Elizabeth Glaser Pediatric AIDS Foundation, based in the Lesotho country office. Dr. Akin manages a team of experts working to eliminate the elimination of HIV, syphilis, hepatitis, and cervical cancer among women living with HIV. And there he leads the foundation's work on cervical cancer prevention and elimination across multiple country programs. Welcome, Dr. Akin. The floor is yours.
Thank you so much, Sarah. Good morning to all our friends and colleagues. On behalf of Elizabeth Glaser Pediatric Foundations, I will be sharing with you our work and our experience in the context of integrating HIV and cervical cancer prevention in Lesotho, which definitely we consider as an essential steps towards elimination of cervical cancer. The next slide. Okay, thank you. So here is one of our nurses who have just provided health educations in one of the universities in Lesotho. And here we can see a student of the university, I think she was about 28 years old, who came forward to have both HIV testing and cervical cancer screening at the same visit in the university health clinic settings. The next slide. Yeah, so what do we do in the context of integrating services for cervical cancer and HIV? Whatever we do, sustainability is a key consideration. Yeah, because as we will see later, anytime you are bringing in any new innovations, the concern of the people is that will this be sustainable at the end of the day? Yeah, so when we integrate services and we implement programs, we always ensure that we build sustainability into it. And there are 4 strategic approaches which definitely we use to ensure that the sustainability is built into our integrated program. At the country leadership level, we support policy frameworks. We work with the government to set up technical working groups for cancer preventions, support development of guidelines, which will be used to implement a program, ensure that we have standard operating protocols, which will guide healthcare workers to know precisely what to do. And at the same time, we develop health education materials for community literacy to ensure that the community are well informed about the concept of cervical cancer, its prevention, and also to understand how it is related to HIV in one way or the other. We ensure that we support government on partners coordination, because definitely you discover that almost in every country you have more than one partner supporting the government or the Ministry of Health. Yeah, so we work with the ministry to ensure that there's a proper coordinations, and that's where we ensure that there are technical working groups. So we have a cancer control technical working group, which help to coordinate issues relating to cancers, and definitely with high focus and priority on cervical cancer preventions. We ensure that there are quality standards. So yeah, in as much as we want to offer integrated services, but we also want to ensure that we are offering services which will be beneficial to the community. So we have to ensure that there are quality measures which are put in place. So we ensure that there are things like algorithm. We help the Ministry of Health to develop algorithm for cervical cancer preventions. We go on a site improvement monitoring system, which is one of the very strong paper program, which help to ensure consistent implementation of quality services. Then we do regular performance monitoring. From time to time, we have joint supportive supervisions, which comprises of the donor, mainly PEPFAR, the Ministry of Health, and us as implementing partners visit the program together, review it and assess it, identify gaps, and put measures in place to ensure that such gaps are filled. Concerning monitoring and evaluations, we assist the government to develop tools that are needed for implementations, screening registers, where patients' data are documented. We have cervical cancer client cards, which allow the individual to be able to carry the record of her own screening. So all the women who had ever been screened for cervical cancer in Lesotho, especially in the last 5 years, they carry a personal card, where the documentations of their cervical cancer screening is imputed, so that wherever they go, you can actually see the history of their cervical cancer screening. Then, in addition to that, we assist with reporting tools to ensure that data are well captured. They are imputed into government systems like DHA IS2, into electronic registers, and also we work closely with program manager to ensure that they can make use of data. It's not just gathering data, but for them to be able to gather data and use it to be able to inform program planning, to be able to design, to be able to quantify resources, and so on. We support on issues relating to supply chains. We procure equipment. We work with governments to quantify needs regarding cervical cancer preventions. We buy commodities that are needed for service integrations, for cervical cancer screening, and we work together with the supply chain system to ensure that resources that are needed for cervical cancer can actually reach all facilities without delay. So to ensure equal distributions and equal access to resources that are needed for cervical cancer screening. We do direct service delivery. We have nurses that actually go there. We have doctors that screen and offer treatment. But beyond that, we do a lot of capacity building. So we identify gaps, capacity gaps. We train doctors to be able to do thermocoagulations, to be able to do loop electrosurgical excision. You see our previous presenter from United mentions about their work regarding optimization of thermal ablation. So in Lesotho, all public facilities in Lesotho are actually having a thermal ablation, courtesy of the PEPFAR program. So we ensure that all our nurses are well trained, those that works in the HIV programming, those that works at maternity, MCH, they are well trained to be able to offer thermal ablations as needed. As of today, our program had mainly been the visual inspection using both acetic acid and local iodine. There's some degree of a pap smear for postmenopausal women. So for women who are definitely screened with visual inspection with acetic acid. For those that screen positive, they are offered treatment immediately, where they are suitable for thermal ablations. And where that is not possible, they are immediately linked to facilities that are able to offer loop electrosurgical excision procedure. So all our districts, as of today, there are 10 districts in Lesotho. All the districts are equipped with thermal ablation with support from PEPFAR, using both mechanism of CDC and USAID. So that definitely has improved access to cervical cancer screening treatment in Lesotho. Right now, the program in Lesotho is transitioning to HPV testing. Dr. Kala spoke about HPV testing, especially following the adoptions of the cervical cancer elimination strategy. We have been working on it since then, but as of today, things are already in place. So we are working with our laboratory to ensure that all gene experts which are available in country. We got support from United some 7-8 years ago on our EID program. And as of today, we are leveraging on those gene experts to ensure that we will use them for HPV testing. It has started already. As far as I'm speaking right now, there are probably close to about 4,500 HPV tests that have been done using gene experts alone. However, in addition to that, our output platforms, covers 6,800, 5,800, they have already been configured, they have been verified, and anytime from now, we'll also be using them for HPV testing. So We work together with the Ministry of Health to ensure that the various documents which will be needed are put in place. Already we've developed a guidance document for HPV implementations. We have the training materials being developed. We have standard operating protocols, which are already going for printing, that will be used to ensure that as we transition from pap smear and visual inspection with acetic acid to HPV, it will be done using the appropriate algorithms as recommended by WHO to ensure very high quality standard of integrated services. So that is what we do. How do we go about it? The next slide will show us about what we do. Next slide, how we go about it. Next slide. Yeah, so definitely service integrations come with some challenges, especially in its initial phase. And this is the process which we do follow in Lesotho. We've used it for so many of our program. We've used it for PrEP, we've used it for TB. However, I will be talking in the context of cervical cancer this morning. These are key things that we do to ensure that our programs that we want to integrate are successful at the end of the day. We do high-level strategic engagements. So definitely we interact with program managers, HIV program managers, sexual and reproductive health program managers, non-communicable disease managers, directors, and other leadership in the Ministry of Health. We have close discussions with them. And we discuss the opportunities that are available with them and what we think will be the outcome of such integrated program at the end of the day. We make them to understand the resources that are available. So definitely there's a need for resource transparency. Yeah, we are funded primarily by PEPFAR, and we'll make them to understand this is the amount of resources, money that is available for cervical cancer implementations. This is how we plan to use it. This is what we think we will achieve if we use it this way. So we work together. They know what is available. And if there are other partners also that have one thing or the other to support cervical cancer programming, they also make us to know what other people are having so that things are harmonized to avoid duplication. And by doing that, we'll discover that the resources that are available are able to reach the maximum number of people, thus making the highest impact that is possible. We do collaborative planning. One thing that healthcare providers don't like is that they don't want you to design a program for them. They want you to design a program with them so that they bring in their own input. And at the end of the day, we have a consensus and a collaborative planning on how to implement those programs. So when that is done, you are going to get their buy-in. And at the end of the day, it becomes our program, not their program. And so that is very, very important. Then we do stakeholders involvement. They are significant key players. For example, inside every country, when you are talking about cervical cancer, you want to carry WHO representative along. You want to discuss with them. You may need some skills, which they may want to provide. We have institutions like the UNFPA, which have key interest in women. We have cancer societies. We have civil service organizations. Yeah, so they are key partners. And in the planning of an integrated program, they have to play a critical role to ensure that everybody bring in their input. And when we reason together, we are able to get maximum cooperation. Definitely, there are a lot of technical expertise from both CDC and USAID. So we all work together, leveraging on our cancer technical working group to plan together. Resource development, definitely, we plan together, we allocate resources, we agree on the best use of those resources in terms of quantity, quality, to ensure that programs that are implemented will definitely make impact across all initiatives. Then implementation and reporting. We execute whatever plan we agree on with high precision and we report regularly both to donor on monthly basis, to the Ministry of Health, maybe on quarterly basis, to program manager, to higher authorities like the ministers, principal secretary, either on every 6 months to see how things is being done. Yeah, and other stakeholders also participate at the regular quarterly technical working groups where project implementations and achievement are reviewed, and where there's need for re-strategizing, we plan together to ensure that is done. And we do high-level advocacy. Definitely, we ensure that we get the necessary backings of relevant people and authority. Yeah, we advocate to directors, director generals, principal secretary, ministers. We have reason to visit the parliaments of Lesotho to advocate for issues relating to cervical cancer. And one of the things we did successfully with both the parliament and office of the prime minister, as Elizabeth Pediatric Foundation, was the integration of a human papillomavirus vaccine as an integral part of the national immunization program. So as of today, HPV vaccine has fully been integrated into the immunization program of Lesotho, and that's as a result of some of our high-level advocacy. Yeah. Next slide. So here you will see the HPV vaccination coverage for girls in Lesotho. HPV vaccination was first piloted in Lesotho between 2010 and 2013. Yeah, but however, as a result of some challenges within the countries, some instability, the program will not be continued. But as a result of continual effort, advocacy, like I mentioned earlier, the government of Lesotho had actually approved HPV vaccination, and it has been incorporated into the immunization program of Lesotho. Yeah, so it was reintroduced in 2002. As of April this year, this is the national coverage. You will see that 2 of our districts have achieved over 95% coverage of the target population. 3 of the districts, they are between 75 and 94% of the target population. And then we have 5 of the districts which are between 55 and 75%. So definitely those are the districts which are being targeted and being where efforts are being put in place to ensure that the coverage goes up. So as of today that we are speaking, the age for HPV vaccinations, following a lot of advocacy, especially with a lot of support from PEPFAR, has actually increased from 14 years to 18 years for the general population of girls. Yeah, so we now vaccinate our girls up to the age of 18. For
Dr.
those
Agnew?
that are living with...
Just want to know, we need to move towards closing. If you could move into your wrap up, that would be great.
Yeah, so for those that are living with HIV up to 24 years. So next slide. Yeah, so this is a program implementation, which was scaled up from 2018. At about 2021, having achieved a national coverage, in the context of sustainability, we actually begin to transition services to other local implementation. Yeah, to ensure that even if ECPA have a reason to exit, there will be other local institutions or organizations that will be able to carry on the cervical cancer activity. Next slide. Yeah, so there are definitely challenges, and as we manage those challenges, when you are integrating program, the first concern of people is the issue of sustainability. So you want to discuss that with them on how to achieve that. Then at times, healthcare workers see it as increased workload. However, you want to make them to understand that when services are integrated, it's actually a way of reducing workloads. Then definitely there's this fear of a skills gap. They are worried they may not be able to perform. We work together to define the gaps and to put training materials in place, to put mentorship or program in place to ensure that they are properly mentored and well trained. I think that should be the last slide. Next slide. Yeah, so this is somebody who has benefited from an integrated program. She came for, that's the previous slide, came for cervical cancer screening, was also screened for HIV, was HIV positive, was initiated on AROT, at the same time was offered treatment for pre-cancer of the cervix, and at follow-up in 1 year, follow-up treatment showed that she was cured of pre-cancer of the cervix. So thank you so much for this opportunity to make this presentation on behalf of Elizabeth Gate Foundation.
Thank you so much, Dr. Atkin. And we're really grateful also, not only just hearing what is going on the ground, but for you to bring forward sort of the names and faces of some women that have been a part of these services as well. That's really grateful for that moment. And finally, we're pleased to introduce Dr. Allison Footman from ABAC to kind of round out the discussion with some key advocacy and future recommendations. Allison is the Senior Program Manager of STIs at ABAC, where she manages the development of an STI vaccine and diagnostic advocacy program. Prior to joining ABAC, Allison was a postdoctoral fellow at St. Jude Children's Research Hospital, where she conducted research focused on improving HPV vaccination rates in the United States. So Allison, the floor is yours.
Thank you so much, Sarah. So we're going to move through these slides. So a lot of time when thinking about advocacy, HPV, cervical cancer, and HIV, there's a question of why should we care? So we should care because long-lasting, persistent HPV infections can lead to cervical cancer. Cervical cancer is the 4th most common cancer in women globally. In 2022, there were more than 600,000 new cases and more than 300,000 deaths related to cervical cancer. When I think about those 300,000 deaths, I think about the 300,000 or more than 300,000 families that were impacted by these deaths. Women living with HIV are 6 times more likely to develop cervical cancer compared to women who are HIV negative. And the highest rates of cervical cancer incidence and mortality are in low and middle income countries similar to HIV. Service integration is needed to better prevent and treat HPV, cervical cancer, and HIV. And so when we look at these geographical distributions, we can see that the mortality rates of cervical cancer are disproportionately in East and Southern Africa. And so we see that within this graphic. And then when we go to another graphic of HIV incidence, we see a similar picture of incidence rates being highest in LMICs, but especially in Eastern and Southern Africa. And so it really poses the question of if cervical cancer is 6 times more likely in people living with HIV, how do we ensure that they are able to prevent these infections, prevent HPV infections in these countries and communities most impacted? And so it's important to note that cervical cancer and HIV are preventable. Today, I will focus on cervical cancer and the HPV vaccine, which can prevent 6 types of cancer and genital warts. In 2024, researchers in Scotland found that no cases of cervical cancer in women born between 1988 and 1996 who were fully vaccinated against HPV at ages 12 to 13 years. And so again, this really just highlights how there weren't any cases of cervical cancer among those who were vaccinated. However, we see the story of vaccine shortages and disruptions in the supply chain that can impact girls in Africa. And so it really brings the question of if women living with HIV or in communities with high HIV incidence rates were vaccinated, could we see similar results of no cervical cancer within their lifetime? And so it really makes us think, how do we ensure that people have this vaccine to prevent cervical cancer? Oftentimes when we talk about vaccines, we ask this question of if we build it, will they come? Will they actually get vaccinated? And with the HPV vaccine, we see that in 2022, it was estimated that 21% of adolescent girls had received at least 1 dose of this vaccine, which was a 5% increase from 2021. We see that 73% of countries include HPV vaccination in their national immunization programs. And we also know that HPV vaccine introduction, coverage, and scale up is impacted by costs, health system constraints, patient and policy barriers, and supply chain issues. So when we ask this question, if we build it, will they come? It's a maybe, because maybe they will. But really, we should be asking ourselves, if we build it, will we make it accessible? And in thinking about that, we have to ask, is the vaccine accessible? Is it affordable? Have we communicated why people should get vaccinated? Do people trust us and the messages that we are delivering about this vaccine? And have we proven to people that the vaccine will benefit them and protect their health? What policies are needed to promote vaccine introduction and implementation? And is this the vaccine that people want? Do people really want to get vaccinated? We have to understand the answer to these questions to really meet community needs when it comes to providing HPV vaccines. And so I'm thinking, if we build it, will we make it accessible? We should. And we have a lot of work in making HPV vaccines accessible to everyone who could benefit from this vaccine and to everyone who wants to be vaccinated. And so in thinking about some of that work, advocacy is it is important. And at AVAC, we have a lot of webinars that focus on cervical cancer, HPV, and HIV. And so I really wanted to highlight some of the quotes from our advocates that presented in these webinars. And so we have Tamika, who said, "We all contribute to the elimination of cervical cancer." We also have Karen, who said, "I didn't realize how much power my voice had." And this really shows us that we all have a role when it comes to preventing cervical cancer, when it comes to providing HPV vaccines, but we really have to examine what is our power and how are we empowering others. Additionally, at AVAC, we have an STI subaward program that funds typically HIV advocacy partners in East and Southern Africa to really examine STI advocacy needs, including for HPV vaccination. And so I want to highlight some of the quotes from these advocates as well. We have Mandisa, who says STI prevention, diagnostics, and vaccines costs are much lower than dealing with neonatal deaths, deaths associated with cervical cancer, and AMR. STI prevention is an emergency. We have Simon, who has stated there are significant opportunities to improve STI prevention, ensure equitable access to vaccines and diagnostics, and advocate for sexual health rights in Kenya through policy changes, community mobilization, public-private partnerships, and comprehensive educational campaigns. And then finally, we have Henry, who says, key population civil society organizations play a key role in information dissemination about STIs to their community members. And I think what is so powerful about these quotes is that they're providing us the answers for what we need to do to get HPV vaccines into communities and why this is so important. We have to work together. We have to work with communities. And so we know that we can prevent cervical cancer. We know we can prevent cervical cancer among women living with HIV. The question now has to be, how do we really work together? How do we build these relationships? And how do we ensure we are meeting the needs of communities and the people who could benefit from this vaccine? And so with that, I am done, and you can always email me for questions.
Thank you so much, Allison. Brilliant job and important reminders of the role of advocacy and kind of community and narrative as well when we're doing this work. But I want to ask all the speakers to come back on screen if you can. We're going to kind of move quickly into a couple questions that we've prepared and some that you've submitted today. So thank you so much. To do that, I want to introduce our wonderful moderator today, Jenny Sherwood, the Public Policy Manager at amfAR. In this role, she leads amfAR's policy-related project portfolio in the areas of gender, women's health, and sexual and reproductive health and rights. So Jenny, I'll let you take it away.
Thank you so much, Sarah, and thank you so much to the panelists for such an inspiring conversation, really informative. Thank you. So given time, there's been some excellent questions that have come through from the audience, and so I will bucket those into a few groups, and then if we have time, move into some closing thoughts. So the majority of questions that have come through have really focused on this issue of equity and access. I think there's been a great discussion of the kinds of tools that are available, but how we get those to people is what's really coming through. So this first question is, is focused on, it's from Peely Tomlinson, and it focuses on for some women, girls, trans men, and gender diverse people, cervical cancer screening and treatment can be particularly uncomfortable, painful, or re-traumatizing. What are some good practices that communities and healthcare providers are using to support the needs of women, trans, and gender diverse people to access care? So, or are there gaps in this area that we need to be better addressing? The second question, and I'll just ask both, and then if anyone would like to answer, is also about a gender equity question, and that is what and how can we also focus and target men? We ask, while we do focus, and there's an agreement that we should be prioritizing women, if we really want to eliminate cervical cancer, we also need to pay attention to HPV in men. And so how can we do that through our programming as well? Is there anyone that would like to start off with either of those questions?
Yeah, for the second question, I think I can come in. The easiest way to prevent men from acquiring HPV infections is to ensure that there is no woman that carries HPV viruses. So if you fully vaccinate all the women and they are no longer repository for HPV, they will not have a way of infecting men. So where resources are limited, the first thing is that ensure that all women are fully covered. Then when you have additional resources, you can now begin to focus it on men. Thank you.
Thank you, Dr. Akin. Others?
I think I just want to add to this conversation. The HPV vaccine is such an amazing tool. So again, it prevents against 6 types of cancers, including cervical, oropharyngeal, which will be your neck and throat type of cancers, anal cancers. And what we're seeing a lot of times is that we have had these female prioritized vaccination campaigns, which have been phenomenal in preventing cervical cancer, but it has really left gaps in preventing some of the anal cancer, the oropharyngeal cancers that we're starting to see among men, but also sexual and gender minorities. And I think what is really exciting is that there's a push within the research community to really understand how to expand vaccination efforts. And I think one of the things that we need, as others on the call have mentioned, is additional resources so that we can expand vaccination efforts globally. A lot of times we only have the financials to provide vaccines for adolescent girls. It's important to remember that right now the HPV vaccine can be administered to people up to 45 years. I mean, that is incredible in thinking about eliminating HPV-related cancers. And so when we talk about this elimination, we have to, I think about all of these cancers and genital warts that could be prevented, and understanding that we need the resources to provide these vaccines. And we also have to make sure that people understand the benefit of vaccination.
Thank you so much, Dr. Footman. And Dr. Chibuesa, I saw you come off mute. Do you have other thoughts?
They've mostly been covered by Dr. Footman. I was just going to underscore, I think, from a research perspective, the importance of investigating and developing ways to address or mitigate vaccine hesitancy, misinformation, disinformation, and anti-vax sentiments. Because this is primarily an adolescent vaccine, or differently said, is a vaccine that's most effective if given to adolescents. There is also a lot of engagement, of course, with parents, and so I think that makes it different from other vaccines that we give to adults that are cancer prevention vaccines like Hep B, for example.
Thank you. Yeah, and I wanted to just, I know we're at time, so I want to be respectful here. I want maybe one more sort of question for Dr. Young and Ms. Milka, and then some closing thoughts. Dr. Young, it was so great to hear about the incredible work by the administration, really across cervical cancer and women's health realms. I wanted to ask maybe to hear a little bit more about the international collaborations that have brought that to the fore and the role that you really see private funders being able to do in these initiatives, and what are some key areas that we can expand or improve.
Yeah, thank you so much, Jenny. And I'll just take a few minutes because I know we are tight on time. I think international collaboration is the key here. And I have been so encouraged to see how partners, not just within the federal agencies, but, between countries as well, who have just been so enthusiastic and motivated to see us really drive towards eliminating cervical cancer, which I do believe is possible within our lifetime. I mean, as everyone has said, we have the tools and resources. We just need to get that accessibility piece figured out. And I think we can do that. So I'm very encouraged by our international collaborations, and the Cancer Moonshot has several in the pipeline, which over time we'll be very excited to share more broadly with this group as well. The last thing I want to just plug really quickly is that one of the most important, I believe, tools we have as the Cancer Moonshot is our platform to be able to amplify the amazing work that is happening. And what I would like to propose to all of you on the screen and those who are watching is at the end of June, we are going to be releasing what we call a fact sheet, which essentially is our way of announcing new commitments and announcements that the private sector and federal agencies are making in a very public way, and to show our support for you. So if there is anyone on this call that is looking to make a commitment or progressing their work in some capacity who would like to be a part of this, please get in touch with me through Jenny or others on this call. We would love to have you incorporated in this work as well. So Jenny, back to you. Thank you.
Thank you so much. And this actually is a good way to close and just sort of hear briefly from each panelist, really about what the key takeaways are that you feel we can take away from the event today. What is most urgent? What is the most impactful place for investment? Really speaking to the funders and researchers that are on the line today. Where can we fill gaps? What can philanthropy do? And I know, Cervical, you've been thinking about this and about access a lot, and your presentation was great in really thinking about how we can build off of HIV infrastructure. So I'd like to start with you, perhaps if you have thoughts, and then we can move to others.
Thanks so much. I think maybe 2 points to emphasize. One thing is that even though HPV testing is cost effective, it does not mean that it's affordable. And we have been really struggling with that component of implementation. And it's not going to work if we just look at the standard ways of financing, especially the HIV response. We need to really tap into domestic financing and some other innovative financing options for cervical cancer. And I think, what PEPFAR has done, what we are also seeing now, Global Fund more and more doing, is including the component of cervical cancer response for women living with HIV. But we are now seeing in countries that kind of shift of cervical cancer burden onto the women who don't have HIV, and most of the cases of invasive cancer now in that population more and more. So sorting out the financing agenda, I think a lot more can be done on demonstrating effective service delivery models, getting the affordability better for some of these tools, especially HPV testing, but then the domestic financing is probably one of the ways to go in this area. Yeah, maybe I'll stop there. Thank you.
Thank you so much. Dr. Akin, final thoughts, takeaways for funders?
Yeah. Funders should work with leadership. There is need for high-level advocacy to carry leaders along. If leaders are well motivated, every other people will respond to them. Then the other thing is that all countries have something they can start with. Yeah, they may not have everything, but the truth is that there are some resources that are available. especially maybe countries that have invested so much into HIV, there are things they can leverage upon. They have equipments which can be leveraged upon to start HPV testings. Thank you.
Thank you. And maybe Dr. Chibwesa, if you have final thoughts, also bringing in, I know you had mentioned some incredible research that you had been a part of, and if there are any sort of recent breakthroughs that we should be taking a look at and keeping an eye on that you want to have us look forward to.
I think on the research perspective, the highest impact areas are going to be around vaccine implementation that we've already mentioned, and ensuring that we continually update and address anti-vax and vaccine hesitancy sentiments. And then on the testing side, I'm certainly not yet ready for prime time, but ready for more investment. Point of care tests that use technology called lateral flow, which makes them extremely rapid and functions similar to a pregnancy test. So I think that's a very exciting area of development, but again, needing more more R&D type funds. Definitely not ready for prime time. I also mentioned, but I think it is a secondary issue, the need for more effective treatments for women living with HIV, and certainly. The first priority with treatment, as others have mentioned, is to scale up ablative and excisional technologies that we already have, but then in parallel, sort of working to figure out whether we can have multimodality treatment for women with HIV so that they can achieve cure from precancer and not need to keep coming back.
Excellent. Thank you so much. Dr. Footman, final thoughts or takeaways?
Yeah, thank you so much, Shani. So my final thought is that I'm a strong believer in that communities know what they need to be healthy. And no one or most people do not want to die from something that is preventable. And so we have to invest in communities, and we have to let them lead some of this work and these conversations, because they're the ones who are there every day in their communities with their neighbors, where they're talking about their experience. They're saying who to trust and who not to trust. And we have to invest in those conversations, and we have to prepare people to talk about HPV and HPV vaccinations to prevent cervical cancer. So whether we're investing in the US or we are investing more globally, we have to invest in communities and the people and listen to them, because they know what they need. And they also know that they don't want to die from something that is preventable.
Yes, well said. Thank you so much. I think with that, I will, Dr. Young, did you have any final thoughts? I know that I started with you.
I mean, just to agree with everything here, I think when funders look for opportunities, education, awareness, prevention, detection, treatment, access, these are all avenues that are so critical for us to reach the final goals, and all areas that funders can really create their own pathway and unique kind of input into where it aligns with their goals as well. So I think there's many opportunities here along the pipeline, from prevention all the way through survivorship, and hopefully in the end, complete elimination as well. So, and I'll leave it at that. Thank you so much.
Thank you so much. And thank you all for being here. Thank you so much to FCA and FRE as well for co-hosting with us. It has been a pleasure. I'll turn it back to you, Sarah.
Thank you so much, and to all of our amazing speakers today. There's such a plethora of information. We'll be sharing kind of slides and the recording so we can make sure to kind of share this more widely. And if you have questions that weren't answered or that have come up from this presentation, feel free to share with me, and we'll make sure we kind of get those to the speakers as well. I do want to say, and not to take credit for, but I'm excited to announce that in the chat, I put the link to a new white paper from amfAR on this exact topic. You heard it here first, this breaking news. So we really encourage you to spend time with that and think about how that can inform sort of your work that you're doing. And also, this shouldn't be a first or one and only conversation. If you're headed to Munich for AIDS 2024 in July, there is a pre-conference session on sort of HIV and HPV related cancer. So we encourage you to attend that. FCA will be announcing our call for sessions for our 2025 Global Philanthropy Summit in January. That could be a place where we could create a session for this conversation and bring more donors to it. So let's keep talking. Stay tuned here, and we'll try to keep this conversation moving. But thank you so much, and thanks for staying over as well. Bye, everyone.
Bye.
Amazing.
Bye.
So much.